Good afternoon. So if I'm looking at the registration of everyone, I see we have quite a mix of groups. Some of you are case managers, some are more epidemiologists. Hopefully at the conclusion of my presentation, there will be at least some pearls of wisdom for you to think about and take back home, and think about the practical application what we do as case managers. So there are some specific objectives that you can see. Obviously, we want to be able to describe the several components of TB case management. There's lots of different forms of case management. We're going to focus specifically on tuberculosis. You should be able to identify and prioritize the objectives for case management. You should be able to identify the components of a clinical evaluation. Now, of course, as nurses, we aren't making the diagnosis, but you certainly have to be familiar with the clinical aspects of TB and how it relates to your role as the case manager. We're going to touch on the core treatment regimen. How many of you are aware there are new ATS guidelines for treatment? Okay. So we're going to touch on that, and then I believe you have another session tomorrow or the next day with more in depth. But very important as case managers that you understand the treatment regimen and the key things we do to promote adherence. So here's my definition of case management, right? Primary responsibility for the coordination of patient care to ensure the patient's medical and psychological needs are met. And it's important, the last part, through the appropriate utilization of resources. And we try historically to be everything to everyone. Well, I think most of us have budgets to be concerned with, so we really have to look at how we are utilizing our resources. Does someone in the group want to share your definition of case management? This is mine. Anything different when you think of case management? We can go with this? All right, we'll go with this. All right, so here's some of the goals. So obviously we're trying to render the patient non-infectious through an appropriate course of treatment. And if you look at objectives under the course of treatment, what's one of the main things we're trying to do? We're rendering them non-infectious, but how are we doing that? What's the role of the medication? Kill the bugs, absolutely. So we want to rapidly decrease the number of organisms that this patient has, right, by making sure the medications they have are appropriate and effective for that patient. Very important. The second kind of goal, sub-goal under rendering them non-infectious, we want to try and take them to cure, right? It's not just treating them. We want to cure them. We want to prevent relapse. Therefore, we have to ensure they complete all of the medication. And then obviously, we also want to ensure that the medications are safe for the patient. Does not cause any harm. So, early intervention, what does that mean? We want to provide early intervention. What do we need to be able to do that? What? We have to find them. There has to be a diagnosis, and the healthcare provider has to do what? Report. Very basic. If we don't know about the patient, how can we as public health intervene? And besides the provider, who else should be reporting? Laboratory. So we have a dual mechanism of reporting. Now, there's a few people from out of state, but I think most of you in California are familiar with CalReady, yes? And electronic lab reporting. So one good thing now through the electronic disease reporting system through the California Department of Public Health is that there's an electronic lab portal. And the law requires all clinical laboratories to report through ELR, which really increases the likelihood that we're going to get that lab result in a timely manner. However, do we have everything we need from that lab report? No. Sometimes no address, or you don't have the clinical, you don't know if they're on treatment. So it's still the provider's responsibility to report, even though we're getting it through lab. So very important. Now, so we're rendering our patient non-infectious by getting them on treatment, reducing the count of organisms, giving them safe medications. We're learning about the patient through timely reporting. Our intervention is, of course, assessing that patient, knowing where they are they infectious? All of those things are part of the various steps for case management. We want to prevent TB transmission. Now, how are we going to do that? Johnny Jones has active TB. How are we going to prevent transmission? Isolation. That's right. So if they're communicable, they should be isolated. Obviously, treatment is important, but it takes a while to have them rendered non-infectious after medications are started. But the meds are very effective. We're trying to prevent further development of disease in the patient. We don't want the disease to progress. But how are we going to break the disease transmission cycle? We're treating the patient. We've isolated the patient. What else should we be thinking about? Contact investigation, right? Our patient already has TB, so we can't prevent them from getting disease. But if we're timely and we're intervening with family members, getting them tested, evaluated on window prophy if indicated, we hopefully can stop disease transmission. So that's very important. Now, another goal, identify and remove barriers. So should we have tunnel vision and only think about TB when you go in as the case manager? What are some of the other challenges our families are facing? Transportation. What else? Homelessness. What else? Language barrier. What else? Drug abuse, alcohol abuse, hepatitis C, mental health issues. So we cannot afford to only look at TB. We must be aware of the other problems, the other urgent needs. Diabetes, out of control. What else does this patient need so that they can focus on their TB treatment? So as a case manager, you have to take that holistic, comprehensive look at your patient and not just think about TB. Now, is TB on the top of our list? Obviously. Is there TB treatment on the top of our list? Obviously. But you have to think about it from the patient's perspective as well. And obviously, we all should be doing patient-centered care, patient-centered case management. All right, so there's a very fundamental things that you're held accountable for as a case manager. You see them here. So ultimately, you're held accountable to ensure the patient completes an appropriate course of treatment. You're not writing the orders, but should you be able to recognize if the order's not appropriate? Yes. Should you be able to recognize that you have a 200-pound individual only on 800 milligrams of ethambutol? Yes. Should you be able to realize that the AFB cultures are pending, but the provider feels like this is LTBI, therefore they've only put them on INH, but you have an infiltrate on X-ray? Should you be able to recognize that? Obviously. And within your system, you have to know who you take that to. If you're not the one that's the case manager that's calling up Dr. Jones and saying, dear doctor, here's some concerns with the patient, you take it to whomever it is. So all of that is helping us ensure the patient finishes or starts and then finishes an appropriate course of treatment. Education is so important. Educating the patient about TB and its treatment and management. But let's say you have a patient with a positive AFB smear, and Mark talked about all the different labs, right? So you have a positive AFB smear. You don't have a gene expert. You don't have a PCR that's been done. Are you going to tell that patient who has that positive AFB smear, abnormal chest X-ray, symptomatic, that they definitely have TB? No. And why not? Could be something else. What is that something else? It could be MAC, absolutely. So they could have mycobacteria other than MTB. So it's that thin line, right? If you underplay that this is TB, well, why do they want to bother? But if you say, absolutely, you have TB, you're contagious, you need to do X, Y, Z, and lo and behold, you get your culture back and it's Mycobacterium avium intercellulare or one of the other pathogenic organisms, what happens to your credibility? So it's knowing how to educate the patient, and at this point, these tests appear that you do have active TB, and until we know for sure, here's the precautions that are needed. We can't ignore that positive AFB smear, but you do want to know more definitely that it's TB. So the NAT tests, the gene expert tests, they are giving us an answer sooner, which is very important. But think about that in your educational message that you're giving to the patient. Now, sometimes patients will have both, right? They'll have a dual infection. I have physicians sometimes say, well, they have a long-standing history of MAC. Patient has a positive AFB smear, they're symptomatic, findings on x-ray, they're convinced it's MAC. And so they don't want to treat the patient. But case manager's role would be say, well, doctor, are you aware that sometimes patients have both? And we never, ever, ever challenge the physician's clinical judgment, but it's an opportunity to provide education. If it's not your role, you take the issue to your TB controller, your supervisor, whoever's responsible. So I get questioned about dual infection a lot. I'm now tracking how many times we have a patient with dual infection, because I can say, oh yeah, it happens, but someone says, well, give me how many. So if you're monitoring that in your community, it's an important statistic to share with your provider that during this year we had X patients that had MAC and MTB. It's usually MAC, but it could be fortuitum, it could be one of the others that produce are pathogenic, yes.
So I don't know if I've ever asked my lab this before, but once MAC or some other rapidly growing or NTM pops up on the culture, do they keep going for 6 weeks once something else pops up?
Most labs do, but you would have to specifically ask your lab. Our lab does, and that's how I know I have MAC and MTB. Or it's a commercial lab, right? They're still holding it, and they haven't stopped, and that's why that's so important. Rapid growers, you're going to know in 2 to 3 weeks. TB, it could be 3, 4, 5, 6 weeks.
Yeah.
So know what your lab does. Yeah.
Sometimes it initially comes out as MTBC.
NTB complex, right.
Does it have the potential to grow something else other than TB?
MTB complex consists of mycobacterium tuberculosis, microti, it can include Africanans, so it has different subtypes in it. What the lab can do can speciate out and tell you what's predominant, but it doesn't preclude them from having MTB complex and MAC or something else. The lab has to look at that. And if you have a patient that's MTB complex and they don't convert, they've been on treatment, you have them on DOT, you know they're getting their medicines, they continue to throw positive, you really want to question whether the predominant species in that complex is Imbovus, which is, can be part of the complex.
So if it comes out as MTBC, it should still continue for the culture?
No, if it's MTB complex, the time has gone by, that is your identification. You ask, could a patient also have something else? But if it doesn't show up in culture, then you go with the MTB complex. When it's the complex, though, you don't know which species is the predominant, right? Is it MTB? Is it Bovus, Microti? People from Africa, you can see M. africanans, right? But we accept that as the result. All right. So the other thing in terms of your responsibilities, right, you're ensuring that a patient has documented culture conversion, right? So when we look at culture conversion, why is that important? Means the treatment is working. Now, do we use culture conversion to measure communicability, or what do you use? Smears, right? So what's the criteria for assessing, is this patient most likely no longer communicable? All right, so we're looking for 3 consecutive negative AFB smears and at least 2 weeks of appropriate treatment and clinical improvement, right? So you're looking at those things. Cultures take longer. So our patient can have 3 consecutive negative AFB smears, be on appropriate treatment, and we lift home isolation, right? We let them go back to work, we let kids go back to school. I mentioned earlier in the discussion about the NATs on smear negative patients. You just want to know your policy. You want to really have this discussion with your physician. You saw from what Mark showed how the percent of accuracy in gnats on smear negative buried in, and some of them as low as 50%. So there's new guidelines out. There's an American Public Health Laboratory and National TB Controller Association issued a position statement on the use of gene experts, specifically for gene expert, on being able to release a patient in the hospital who's in negative pressure isolation. How many of you seen them? Some of you, right? And what does it tell you as the criteria for letting them come out of isolation based on 2 gene experts? 2 negative gene experts, right? Whether they're even on smear negative, right? So what is maybe a little caveat you have to think about with that?
It's not completely reliable.
Right. So you really have to think about, so we have a California TB Controller Association, California TB Control Branch work group that's actually working on updating the infectiousness guidelines that has specific criteria for placement of patients in high and lower risk settings. So here's the difference. That document from APL and NTCA addressed release from isolation in the hospital. It does not take into account where the patient is going. So if they're going home and there's not a new baby in the home, or there are not people in the home that have not been exposed, that's one thing. But let's say they're going to a skilled nursing facility. Are you really, if it was your decision to make, really going to have a patient, despite a negative gnat or 2 negative gnats, smear negative, symptomatic, are you going to let them go to a skilled nursing facility based on something where there's still that 40 to 50% margin of error that it still could be TB? It's something for you to discuss in your respective jurisdictions. So you'll be hearing a lot about that. I'm one that says no. But we are putting it in the guidelines with the caveat. It's up to the local TB controller to make that decision, because if you're wrong and you let that person go to an environment and they end up having TB despite that negative gene expert, you have a preventable exposure, and that's part of our job as public health, is to prevent it. So if you read the document, just know it's looking at discontinuation isolation in the hospital. It doesn't account for where the patient's going, which is very important. So you're going to look at your smears before you have culture conversion. And then when is a contact investigation indicated? Is it for every case? Renal TB? TB meningitis? TB meningitis? Who says yes? You need a CI for a patient with TB meningitis, normal chest x-ray. Okay, how is TB transmitted? Airborne. What has to happen? Right? Coughing, droplets in the air for someone else to inhale. So contact investigation is indicated when you have pulmonary disease or laryngeal TB as the 2 main types, right? They allow droplets to get into the air where someone else can inhale them. So that's why it says contact investigation when indicated. So if you clearly have no indication of pulmonary or laryngeal involvement, you don't always have to do a contact investigation. I know you have a session later on that, but know what your protocols are. All right, so some other things that you're doing, you're trying to make sure the care that you provide to the patient really are culturally sensitive and acceptable to the patient. And here's where we think about patient-centered care. What are some of the variables you have to think about that might be a problem for a patient in terms of what they believe versus what we believe? What?
Health beliefs.
Health beliefs, yes. What else? The stigma attached to it. And a lot of discussion about when we're talking, making sure we're thinking about non-stigmatizing language, right? So health beliefs, cultural beliefs, in some cultures having TB, it's just taboo. It's just a very bad thing. No one wants TB, but for some cultures, a person is, in essence, ostracized for having it. So I always share a story of a preschool teacher who was diagnosed with TB. Of course, you know, we took her off work, had her home. She absolutely refused treatment. And so we said, why? We showed her her labs, her x-ray, you know, she was seen in clinic. She truly could not accept the diagnosis of TB. So she wouldn't take her meds. Okay, she has a right to refuse, but what does she not have the right to do? Go back to work. She does not have the right to expose others. So we place her on home isolation, and we periodically would check in. I mean, we're not there 24/7, and we don't post their house to say this person's on isolation. But several times the public health nurse called to check in, different times of day. You have to be strategic, and could never get her. So decided, let's just call the preschool. And we called the preschool and said, is Sally there? Oh no, but she'll be here at 3. So she had gone back to work. And these were in the days before we made sure we sent an exclusion letter to the school so we could hold them accountable. So we had to do another CI because people were exposed again. We had converters. She's one of the instances where we actually took legal action. She was served with an order. We went to court. And having TB is not a crime. Knowingly exposing others to TB is the crime. So short version, long story, we went to court, and what the judge told her was, if you don't do everything the health officer says, if you do not take your medications, you will be going to jail. Okay? So, that's a hard approach, but we did all the nice approaches, and they did not work. The moral of the story is, it was not acceptable to the patient. However, we had to balance the patient's individual beliefs, the patient's individual constitutional rights, with our mandate to protect the public's health. And so after that, she did finish her drugs. She never believed she had TB, but that was all right. She took her pills. All right. Now, our goals. So if you're setting goals, looking at your outcomes, documenting interventions, you can apply for the nurses. What could you apply? The principles of what? Nurses. We should all know it. The nursing progress. I should have some candy. So the nursing process, right? So you do your assessment. You come up with a plan. You have specific goals. You have to evaluate if it's working, and then you modify your plan if you need to do something different. So you can really use the nursing process to really establish your care plan for the patient. Now there are some specific parameters we have to monitor for TB, and we'll look at them in a moment. So you're not only working with the patient, who else do you have to work with? What? Family. Who else? The providers, right? So again, the case manager, you have to see yourself as the hub, right? You're helping to coordinate all the various pieces of the people involved in this patient's care. So as healthcare providers, it could be our community outreach workers, and we see more and more of our patients with mental health issues. That's the challenge. Diabetes, all of that. You have to be aware of all the issues and coordinate. All right, some real practical steps. Of course, you get that report. We talked about timely reporting, and you're going to decide of the urgency of this referral. So what are some of the variables you should be looking at to determine how quickly you should act on this referral you just got? What are some of the things for urgency? Infectiousness, and how are you measuring that? Smear status, right? What else might relate to infectiousness besides the smear? What? Symptoms, as well as do they have cavitary disease? Okay, what else makes this an urgent referral? The clinical, but what else? High risk setting, where are they? Where are they going? All of those things should take into account. Now, how many of you do other diseases besides TB? Are we all? Okay, so now today, you got a rule out measles suspect. You got someone just coming back and from a country with active Zika transmission, and you have a salmonella. How are you going to prioritize?
Are you asking me? We have a list of different importances, and measles would be the first one we would do. And actually, TB would come after salmonella even on our...
On your matrix.
Yeah.
Okay. So those of you who must multitask, do multiple diseases, you really have to think through how do you prioritize. And it is helpful to have a guide that your administration, your supervisor, or as a team that you have established. And part of it is what presents the greatest risk to the public, right? And are we timely to intervene to stop disease transmission? Good. All right, so here's some of the basic things you're going to do. Ideally, within 1 working day of getting that referral, you've prioritized, you want to establish rapport. And of course, the first contact is often by telephone, and that can be challenging in terms of establishing rapport, and it always takes more than that phone intervention. There's no replacement for face-to-face intervention with the patient. If they're in the hospital, to be able to go or have someone go and talk to the patient while they're still in the hospital, very important. You're going to educate the provider about the role of the health department and your role as case managers. How many of you do that? It's a private physician patient. Tell us your strategy.
I don't actually case manage. We have like kind of 2 levels of
Okay.
management, but I tend to be the kind of first person at the medical care provider.
Okay.
And usually it is with a lot of questions. So we kind of run through, what it looks like and give them kind of an overview, just a brief example, and then also if there's somebody who's new to TB, assist them with identifying the resources. But we have a lot of resources that we've created and really kind of personalized to our populations in our state. So that
Good.
helps a lot. And
Good.
they're abbreviated, so
Right.
we don't have to spend a lot of time looking for things.
Good, so you can show them how you can assist them in the care of their patient. How about our oversight responsibility? Who covers that with the provider? What is our oversight responsibility? Anyone? Right? So by law, we're mandated to take steps to protect the public from communicable diseases, and there's specific laws around TB. So our oversight responsibility is that even if a private physician is managing that patient, public health still has a responsibility to ensure the proper things are being done, treatment's appropriate, the workup is appropriate, that contacts get evaluated, that the individual is not out and about in the community, right, potentially spreading disease. So it's important from the start to have, if you haven't done it, before you have that first report from the physician, it's important to have the physician understand our responsibility. So for an example, sometimes the patient's been on meds for 2 weeks, they were smear positive, no follow-up AFBs are done, and the physician tells the person they can go back to work. How would you handle that? You have positive smears, 2 weeks of meds. You're going to let them go back? No. So an oversight responsibility that says, doctor, I appreciate the fact that you feel the patient is clinically improving on their treatment. However, from a public health perspective, to ensure they're no longer contagious, we must have 3 consecutive negative AFB smears and continuation of treatment before the patient can return to work. That's an oversight responsibility. We also can request updates from the physician to make sure the patient's still in care. The law requires the physician to notify public health if the patient isn't coming in, not being cooperative. How many of you in your jurisdictions actually do TB clinic? See, it's getting fewer and fewer. So are most of your patients managed in the private sector? Where are they managed? Or by half and half? So, if you're not the public health's not the provider, then you have to really coordinate with the private provider. All right, and of course then she mentioned letting them know about services. That's very important. All right, so you're going to make this initial contact with the patient, home visit, as I said, or if they're in the hospital. It's great if you can have a TB liaison that makes rounds at the hospital and see patients. We're not always able to do that, but if you can, that's a good way to start the process. Again, you're trying to establish rapport with the patient so that they are comfortable talking with you. The patient has to understand your role as the public health nurse, as the case manager, but also the role of outreach staff. How many of you use outreach staff, non-licensed staff to deliver and observe meds? Okay, so they have to understand the difference between the nurse and the outreach worker. Do you find that sometimes, however, our patients actually relay or say more to the outreach worker than to the nurse? Why do we think that is?
They're seeing them daily, and there's
right.
Or maybe they're more culturally.
And it might be more the cultural relationship there. And what's the role or responsibility of the outreach worker or when they get told something? To communicate. So you want to make sure as the case manager, there's clear lines of responsibility for your outreach worker and the public health nurse, and what things should the outreach worker be telling you, right? Because ultimately you're held accountable. And sometimes, you know, it's a challenge if a patient's telling the outreach worker, my husband or my wife is hitting me, right? Don't tell. Well, obviously they have to tell. So be real clear in your protocols what they can not tell you. You know, little chit chat's one thing, but anything serious, problems with the medicines, all of those things must come to you. All right, when you do the home assessment, the basic things, right? Space, ventilation, you're gonna look at high-risk individuals. And more today, you know, we're looking at, are there safety concerns in the home, right? So, what are some of the challenges you face as a case manager going out in the field? No challenges? What's an example of a safety issue?
Here's a good one.
All right.
So we have a current case who has a big, giant, beautiful marijuana garden right next to it.
Do they have their marijuana card?
I have no
Okay.
idea. They fenced it all up, but it's still very odd. It's like, put your badge away. You don't take marked cars there. Because our county did this new anybody can report kind of idea they did
Okay.
last year anonymously. So to have the county.
In terms of drug use?
What's that?
Report what?
People growing.
Growing, okay.
Yeah. So I thought it was not a good thing.
Okay.
Showing up every day in a county car.
Yeah, so you might want to have unmarked cars.
Like, yeah, it's just kind of stealth.
I think something we'll have to think about with the election, whether Prop, what is it, 64? Which is going to legalize it, so that might present some additional challenges. All right, so you're looking at space, ventilation. Obviously, sometimes there's lots of people in a very small house and the patient doesn't have the luxury of having their own room, but you have to look at, is there a baby sleeping in the room with the index patient? High risk, you know, if they live there, not a lot you can do, but sometimes you think about newborn baby in the home, dad has TB, dad's in the hospital. Are you gonna let dad go home to that new baby that's not been exposed? All right, now you not only are concerned about the clinical status of the patient, so the physical, the psychological aspects, financial, social, cultural. How many of you have social workers on your team? What, do you find it helpful?
Yes.
What do they do?
Housing, incentives, and enablers.
Right, so if you have the luxury of a social worker, they're just such an important part of our team. All right, so we're kind of covered this. It just recaps the importance of the education, checking compliance. Now, there's terminology of compliance versus adherence. So when we're talking about home isolation, are we looking for compliance or are we looking for adherence? I'm looking for compliance. Now we want to be patient-centered and we want to do, you know, patient-centered education, but they need to comply. Versus a treatment regimen, yes, we want them to treat, we want them to be on their meds, but hopefully we come up with a plan that's patient-centered and they are adhering. It implies they are an active partner in their care. We talked about barriers, we talked about contact investigation. What is the difference in the contact investigation versus source case? So with source case, you're looking for the source, and different jurisdictions have different protocols, right? Some people use 5 and under, some people use 3 and under, and whether it's a child's a TB2 or TB3, you're trying to find out in that child's immediate circle who potentially infected them. Versus with contact investigation, you're looking for who that person exposed. All right, it's important to review the medications, potential adverse events, and then always, 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 we start with the least restrictive interventions in terms of legal. So we start with a patient contract. right? That says, here's the rules. It says, if you don't do this, there might be legal consequences. We get the patient hopefully to buy in. You're going to meet the worker at this place, at this time, for your medications. You're going to come to clinic. So we go up the chain. So contract, which technically is not legally binding, but if we're in court, it shows that we've taken the least restrictive measure, right? We can do a DOT order, which is legally binding. They break it, you require someone in your system to report them to the DA, right? We can do an order of isolation, and we can ultimately do an order for detention. These are California laws. Those of you out of state know what your laws are. But we want to do legal at the last resort. Important as you're starting case management to think about termination. Why is that important?
Because you develop relationships with the patient and you want to have an end goal.
Right, right. Everyone hear that? You develop a relationship with the patient. You want to have an end goal. It can be challenging, right? So with our patients, we're treating them a minimum of 6 months. We're seeing them for directly observed therapy. You establish this relationship. And what are the other things we do to try and get our patients to take their meds? We provide incentives. We provide enablers, right? We do all of these things to the point where they indeed may become dependent on us. So we have to prepare them. We have to prepare our staff, our outreach workers. Eventually it will end. So we have a young lady that's 27. She has 2 young children. She is a TB3. She's been in 3 different jurisdictions. We're the 3rd. And ended up with a person that she was, a friend that was letting her stay with her, got evicted. So, you know, she had nowhere to go. And here she is with these 2 little ones. So, okay, our goal, one, is to, you know, have her in a safe environment and treat her. So we've been incentivizing. We're paying, for California, we're lucky. We have some limited funds for housing to facilitate treatment. And we use low-income motels that are self-contained, so there's no shared air, there's no indoor corridors. She's no longer infectious, but even if she was. So, you know, her responsibility is to show up for her DOT. And she missed 3 days in a row. So I call her and I say, Sally, you know, please call me back. I need to know why you missed your DOT. The case managers do that. Normally I don't. But because she's been always asking for more, right? So, okay, I call her up and I say, you know, give me a call. She didn't call back. So 2 days later, she's at the office for her DOT. And she tells the outreach worker that's been dosing her that she needs some clothes. You know, you can't come for your meds, but you want us to buy you more clothes. She must do temp jobs because every 2 or 3 weeks she has a different job. Well, this current job is she cannot wear any metal in her clothing. They make jewelry, so I guess they're concerned that if they scan them with a metal detector, right? So she wanted to get some clothing without any metal. So okay, I said, okay, Sally. We want to help you. You know, we really appreciate that you're trying, you know, to work and take care of yourself and your family. However, I need you to show up for your medications. I said, do I have your commitment? She said yes. So we'll see. That was last week. So the point is, incentives and enablers, yes, you want to use them. And do we know that our patients take advantage of the system? Absolutely. But keep our eye on the goal. My goal isn't to kick her out of the motel. My goal is for her to finish treatment. She only has 3 more weeks. So, you know, we're trying to hold on to her. You're always pleasant. You know, when you chat with her about, you know, what's the issue. We do have a social worker, so I asked the social worker work with her on some life skills. You know, what is her plan? In 3 more weeks, when treatment is done, and I have to say, I cannot pay for the lodging anymore, right? Because remember, appropriate utilization of resources, I need to reserve them for the next patient that we need to house. So I'm hopeful that she will have a plan, because can you imagine 2 little ones? I would feel terrible to say, you gotta go, and where is she going with her children? She does have a car, so we provide gas vouchers so she can get to work and get to clinic. But eventually, case management must end. All right, so steps, real basic, right? Do you have enough clinical information? Where is the patient? Do they need isolation? Are there other medical social problems? We touched on that. And is the regimen appropriate? So I'm going to take just a couple minutes. Where's my time? Where are we? Oh, I'm good. I'm good. Okay, so this is just an example of the new ATS statement, and you're going to post them where? If the people haven't seen it. So this just recently came out, and it's somewhat different. So in here, what I want to highlight, look here. So how many of you routinely, after 2 to 4 weeks of daily, have been going to biweekly therapy? How many as your standard? No? Are most of you continuing, even in the continuation phase, to do daily? Okay, well, this won't be a big deal then. So what it's saying is the ideal treatment regimen is 7 days a week. And recommending, particularly if they are smear positive and cavitary disease, that even during the continuation phase, that you not put them on intermittent therapy. Now the second tier says you can do it. This is the preferred regimen for patients newly diagnosed TB. That's the first one. Second one, preferred alternative regimen in situations where more frequent DOT during continuation phase is difficult. So at a minimum, the recommendations are saying it needs to be 3 times a week and not 2. But ideally, it should be 7 days a week. How many of you are able to DOT on the weekend? How many of you give packets on the weekend? Okay, do you count those doses in your final count? Well, ATS says if they're on DOT, 5 doses, directly observed therapy is equivalent to 7. Although when you read the new guidelines, it says there's not strong scientific evidence, but it appears from expert opinion that it's efficacious, but it needs to be DOT, right? So you want to really be familiar with these new guidelines. You'll see there, it does go through the total number of doses that you need based on the regimen. The core regimen is still INH, rifampin, pyrizinamide, and ethambutol. The milligrams per kilo varies based on the person's weight, particularly for ethambutol and PZA, right? Everyone's familiar. So again, as a case manager, you're looking at this intake. You need the patient's weight to look at the medications to ensure that the dosing is appropriate for their weight. Same for children. So in the new guideline, on this page, it doesn't give you the milligrams per kilo. It is giving you how many doses. There's another page in the document, though, that actually goes through the milligrams per kilogram. And I assume that'll be covered in more depth in the treatment one? Yes? All right, so just be aware of this new recommendation. The other thing to know, that this part isn't really new. If the patient has cavitary lesion, smear positive, and their culture is still positive after 2 months of treatment, what should happen? What? Well, that's trouble, yes. But the treatment normally gets extended, right? So the continuation phase would be extended, and they would end up, instead of being on a 6-month regimen, they would be on 9 months. I think the other thing that's helpful in this new guideline is what to do if therapy is interrupted, right? So it walks through if they're smear positive and they have more than 14 days missed, start over. It's a nice little chart there, so you want to take a look, and I'm sure they would cover that. Any questions? All right. Now, so all these drugs, although we want our patients to take them, have the potential for adverse events, right? So you must be familiar with adverse events related to the various drugs. So with INH or isoniazid, what might happen? Common adverse events? What? Hepatotoxicity, so you can have a drug-induced hepatitis. What else? Neuropathy, so hopefully we're giving them the B6 to help with that, right? They can sometimes develop a rash from INH. Rifampin, also hepatotoxic, can also cause a rash. Not an adverse event, but idiosyncrasy of rifampin is what? What? Change in color of urine. What color? Reddish orange, right? Reddish orange. So if the patient calls you up and they say, oh, my urine is dark, you should be asking them, what's the color? Because dark, is it a dark brown that suggests a drug-induced hepatitis? If it's a reddish orange, that means they're absorbing the rifampin. Or if it's a dark amber, what does that mean? It's just dark amber. What do they need? More water, right? So you can systematically go through and assess what the problem is. Education, right? The key is to tell the patient to call when something's different from them. You obviously want to go through potential adverse events, but where's the line? What do you have to be concerned about? Well, jaundice in terms of symptoms, but in terms of education, if you told them every possible adverse event that could happen, what would happen? They'd be afraid to take the medicines. And the internet is a dangerous thing because some people look up all the adverse events, right? And they just know that they have them. So you educate them when to call you. You educate them when to hold the meds. And if there's a question, someone needs to be doing a face-to-face assessment of this patient. So I share this slide as an example. So you really have to have a standardized protocol for management of adverse events. You know, a rash protocol, a hepatitis protocol. And again, in the new guidelines, they do kind of walk through this. So this lady broke out in this rash, called up, the HSA went out, called the nurse because the nurse, our HSAs don't do assessments, nurses do assessments. Nurse went out, assessed the patient. Here she presented with this rash. Of course, we were concerned. She was not short of breath, no signs of anaphylaxis, but definitely had a severe rash. We brought her into clinic to see our physician, and our plan was to hold all the meds because we didn't know which drug was causing this rash. Now, it turns out that this lady was also taking a lot of herbal medications, right, or supplements, not medications. And so, of course, we asked her to hold those. And how many of you are familiar with drug challenges? You have protocols, right? So that you stop everything, you then wait for the symptoms to subside, and you add them back one at a time, right? You can add rifampin and ethambutol together. Know what your protocol is, follow it. So we did that, we added them back. We never figured out which drug, despite the drug challenge. It cleared up. She finished her treatment and had no more problems with it. Now, we do know there are drug-drug interactions, so be familiar with that. You know, they might cause a problem if you think about anti-seizure medications and INH. You sometimes have to adjust the dosing. All right, so we mentioned enablers and incentives. So we know that an enabler is anything that helps the patient to more readily complete therapy. So these are examples. Sometimes enablers are incentives, or incentives can be enablers. What are some other examples other than what's listed here? What do you guys do in terms of enablers? Are these pretty common? Yes. Grocery gift card. Is that an enabler? Yes? Or do you do it as an incentive?
Probably
an enabler, right? So if we have someone off work because they're contagious and they don't have money, they don't have sick pay and they need food, then you're buying groceries. That's truly an enabler, right? And then what's an incentive? What's the non-political correct term for incentive? Bribe, that's right. Of course, we never use that non-political incorrect term. We always say an incentive, right? And an incentive are examples here. So food vouchers can be an incentive or it can be an enabler. End of treatment gift, movie passes. So we had a teenager, so if he would show up for 5 consecutive days, he would earn movie passes. He went 6 months and didn't earn one because he never would finish come 5 consecutive days. But here's where patient-centered case management comes. Maybe he didn't like the movies. Did we ask? I don't know that we asked him. So if we did not ask him, what would work for him? So I tell the nurses now, ask the patient, what is an incentive for them? We had a little 6-year-old with TB, and so what did she want? Well, first she wanted something just way too expensive, but then she ended up wanting a little princess sachet. You know, they have these little princess things, and that's what we got her. And she really, it was more for the parent, but she would go in the bathroom, close the door, and wouldn't come out to take her meds. So we said to parents, let's talk to her. What would she like? And that's what she wanted. And she took her medicines. So you have to be creative. You have to have funding. For us, again, in California, from the TB grant, we have some limited funds for incentives and enablers and housing. So if you don't have that luxury, then you have to really look at what resources are in your community, in your agency. You know, will churches help? That type of thing. All right. Promoting adherence, obviously, don't need that anymore. Providing accessible care, acceptable care. Most of you didn't have clinics, but you know, patients sometimes just don't come at their scheduled appointment. You know, if they're more than 15 minutes late, should they be turned away? No, right? So we have to try and accommodate our patients. Our patients may not have transportation. Our staff transport them. And of course, if they're communicable, you can't put them on any public transportation. So our staff who are fit tested with N95 will go to the house, pick up the patient, bring them to clinic, wait, take them home. If they're not contagious, then of course we can use there's a service called AM/PM. It's a band service where we contract with them to do it. If they're stable, there's a bus route near their home. We can give them bus passes to get to clinic. So all of those things try and make the care accessible. TB clinic isn't every day in our jurisdiction, so sometimes that's a problem. You know, TB clinic just happened, and now we have a new patient. Sometimes there is somewhat of a delay, so we work on that, trying to get them in. How many of you have after hours? Oh, see, and sometimes patients are working all day, and they feel like they can't take off because they don't get paid. So, all right. Now, I already mentioned utilization of legal interventions, last resort. Always try incentives, enablers, education, all the other things we can do. But ultimately, as I said, our mandate is to protect the public's health. Now, DOT, and what's the definition of DOT? What does that mean? That's what the acronym means. What does DOT mean? Watching. Right? And ensuring what? That they're taking them, right? That they're not putting them under their tongue, that they're not pretending to cough and cough them in their hand, that they're not cheeking them. Have all of you had that experience with some of your patients? Some of them are very creative. So you really have to ensure it's the direct observation of the patient ingesting anti-TB medications by a trained, right, healthcare worker to ensure that the patient ingests his or her prescribed medications, consistently completes a prescribed course. So any of you use schools? Do any of your children get DOT at school? Okay, what kind of experience have you had?
Well, I have a few high school students, so we some college students who just call their school and have their nurses do whatever. So.
Works good? Okay, good. So if you're having someone else do the DOT for you, very important that they understand what DOT is, right? Not sitting the pills on the counter, not observing the student. We had an incident before we made sure they knew what they were doing. The janitor found pills in the trash. So that's not DOT, so we corrected that. You're always correct if there's an issue. You know, it's not meant to be punitive. You always modify your procedure to ensure it's working properly. The other thing to think about kids, if you have, let's say, an exposure in the high school. We had one where we had about 35 kids test positive from an index patient, and we worked with the school first we did a clinic on site with the parents to explain treatment of LTBI, get their consent, and then we used 3HP. Everyone familiar with 3HP, right? Once a week for 12 weeks. We held it on the campus, right? Our nurse went to the school, and the kids, very limited interruption. They came in, got their meds, went back. Came in, but it really worked. So out of that 35, 33 finished their 12 weeks of 3HP. So an effective regimen in large settings. But a key here is you have to have established some rapport with the school ahead of time, right? They were our allies, they gave us the space, they worked with us, and at the end, all the kids that finished got a nice little certificate, and we asked them, well, this might not sound healthy, but we asked them, did they want McDonald's or Taco Bell food certificates? I think it was about 50-50 of what they wanted. It was a one-time treat, We believe in good nutrition. All right, so again, ATS says 5 observed doses is equivalent, not inferior to 7 daily. So DOT strategies, the flexibility is key. Confidentiality. So if you have a patient that's infectious and your worker or you are going to the home and you need to wear your N95, when are you putting it on? Go ahead. Right inside the door, right at the door. Because if you're putting it on in your car and then you're walking along the driveway, what's happening? That's right. You've just breached confidentiality. And some patients are just convinced the whole neighborhood is watching when most of the time they aren't. But patients are very sensitive. And so here we are again, making sure we're doing patient-centered case management, treatment. We had a patient that wanted the worker to go to the back of the house and hand her the meds through the window. Okay, there was no safety issue. Go to the back of the house, ask her the questions, hand her pills. That's that flexibility and being respectful to what the patient needs. There was a mention about the safety in marijuana. Obviously we say to our staff, if your safety's in jeopardy, forget the meds, literally leave. Because there's nothing more important than your safety and the safety of our staff. Then the next time someone goes, we send 2 people. Always think about your safety. I think most of our homes are fine, right? Most of the time there's no real safety issue. It's the rapport you establish, is how you carry yourself. It is establishing that rapport with the patient where they trust you as the nurse or the community outreach worker coming out to help them take their medications. Very important. If you use non-licensed staff for delivering and observing, can they administer? Can they dispense? No. Deliver and observe, because they are not licensed. So there's all kinds of pharmacy laws, BRN requirements. So you really have to know what your protocols, you need written protocols. Like our community workers deliver and observe, but let's say we have a minor. They cannot hand meds to the child. They may hand it to the parent and observe the parent dosing the child. So know what your protocols are in your jurisdiction. Now, DOT for patients, a lot of you had patients being followed by the private sector. Are you doing DOT for private patients? Yes. Who's writing the orders? The provider. All right. So if there was a problem, patient had some severe adverse event, and you're dosing them, who's held accountable? Right. So you have to think about, and again, may not be your decision, but something to discuss is to really look at your protocol. So for us in Riverside County, we don't dose off of private physicians' orders. They must come to TB clinic at least once and see our physician who writes the order, and we dose off of that. We then co-manage that patient. Let's say they're diabetic, who is monitoring the glucose. Who's doing that? The A1C. You have to have clear protocols when you're monitoring. Now, if the private doc is doing it all, it's a matter of thinking through, is there any liability there if there's a problem when they've ordered it? Are you reviewing that those orders are right, that the dosing is appropriate, the medication's appropriate? Again, take it back to your agency, whoever's in your system, and just think about that. Now, how many of you are doing video DOT? Okay, someone describe your system. How about in the back? What do you do for video DOT?
Oh, we have the.
Speak up so they can hear you.
It depends if the patient had the smartphone.
Okay.
We have Skype, or we have the FaceTime.
Okay.
We can do the video like they record the tablet taking medication.
Okay.
Send it to us. And
So they send you, they record themselves and then send it?
Yeah.
Okay, good. Any other systems people are using?
Ours is similar. We require 2 weeks of DOT prior to
In person?
forward in person, making sure that they don't have any factors that would interfere with video, that they've been compliant. And then we use Skype for Business only.
Okay.
That's what's been approved.
So did your IT have any issues with encryption and the security and HIPAA issues around Skype?
So our county uses Skype for Business as our overall program.
Okay.
Database for our email, et cetera. And so we have an individual link that we create a meeting for that individual person, and it can only be used.
And they get a meeting number?
They get a
Okay, so it's secure.
link to that each.
Okay, good. So you have to think about the HIPAA issues around video DOT. Our IT actually, when we proposed Skype, said no. But they proposed something similar, which was GoToMeeting. And each nurse has a password. The patient calls up. We'll have webcams. And you can really observe eyes for jaundice. You can have them show you your skin, open their mouth. But you have to know your patient. Some patients we wouldn't, even after 2 to 4 weeks of being on in-person DOT, we wouldn't trust on video. But it's such a way to expand what we do. So we had a patient that wanted to go home to the Philippines to visit family on DOT. He wanted to continue his DOT. He and the public health nurse worked out the time difference, and she did his video DOT with him in the Philippines. So just think about how advantageous it can be. And if you're in areas where you're driving a long ways, you could drive an hour to get to the patient's home, spend 15 minutes with them, and then drive another hour coming back. People relate to that? So think about how helpful video DOT can be. Now, the assumption is every patient has internet. Is that true? No, not every patient has access to internet or smartphones. When we first started our video DOT, I had submitted a proposal to our IT. One was for Skype. They nixed that. But I also was proposing that we would use laptops that were going to be surplus, right? That we could do that and do a basic internet service provided. But here's what IT said. Can I guarantee they wouldn't be on inappropriate sites? Like porn sites or something. And of course I couldn't. And so we don't provide the laptop. They have to have their own internet service provider. But what we do provide are little small webcams, portable ones, as a way to assist patients. So a good strategy, but have written protocols. Have written protocols about who's going to do it. Have written protocols if there's a problem. It looks like that patient has a rash. Who's going out? Someone then has to actually go see the patient. You never want to replace in-person interaction with the patient. And even with patients on video DOT, the PHN must see them face-to-face, a minimum of monthly, in addition to the clinic visit. Our outcome criteria. So I mentioned, how do we evaluate? Thinking about the nursing process. So here's some specific patient care standards we should be looking at. Are your visits being made within 1 working day of receipt of a referral? This is something how you can assess yourself. If you're a supervisor, it's how you assess your staff. Have we assessed the patient's home to determine the suitability of the home environment as a standard? Assess and address barriers to adherence, right? It's not enough to identify them if we can't address them. Now, one challenge we still have, and I know how many people are successful, mental health issues can be challenging. right? How do you address the mental health aspects? So we have an individual with a diagnosis of schizophrenia, was in the hospital, TB3, for the longest, just refused everything, refused treatment, wouldn't let them do any more sputums. And so, here's one of those legal interventions. There was a conservator hearing. The court gave the conservator for this lady, who could not make the decisions for herself, the authority to require some tests. But here's where I felt so badly. She needed to go to inpatient mental health. She wouldn't do sputums for clearance to show that she had 3 consecutive negatives and on 2 weeks of meds, so I couldn't approve her discharge from the hospital. They used the court order, we didn't ask, but they used the court order and suggested that I felt for the lady, but they did 3 bronchs. They did 3 bronchoscopy to get the clearance specimens, and now she's in a mental health facility getting the care that she needs. That balance, I couldn't let her go without the documentation, and yet she just wouldn't agree. So just know what the rules are in your agency, your state, and do follow them. Always try and do what's best for the patient. Now, the regimen, ATS guidelines we talked about. Contact investigation, if indicated, you want to try and elicit the names within 3 to 7 days at least. And then if the sputum smear doesn't convert, what's the first, and they're on DOT, they've been on meds for 4 weeks, let's say, and they continue to pop positive smears. What's the first question? Are they resistant? So that's where Gene Expert comes in is helpful, right? It will at least tell you they don't have rifampin resistance. What's the next question? They're on DOT, they're not resistant, they're continuing to be positive. It's the dosing, but you caught that at the beginning, right? You caught that they were underdosing the patient, or you caught that they didn't have the right regimen. But the other thing that can be an issue is absorption. Right? They're not absorbing the medications. We just had this scenario with the patient, just wasn't absorbing, and our doctor increased I always cringe, but increased the rifampin up to, it went up from the 600 to 1200. Did new peaks and troughs, right? The trough was the baseline, the peak. Where are they at the end? He still wasn't absorbing. He just was not absorbing. We were not sure. Now he has a PICC line, and he's getting, because we couldn't convert him. He had been on meds for 4 months, and he was in treatment failure. He was not converting. So he needed additional drugs. So he has a PICC line, and some other drug was added. Pay close attention for failure to convert. That's your role as the nurse, not your role to make the orders, but your role to be monitoring. They're not converting. Take it to case conference. Take it to your physician to really look at what else can be done for this patient. So we'll have to see now how he does. Psychosocial needs, I mentioned, very important. Everyone's familiar with RBCT? Yes, we love it, don't we? So the good thing about it is specific indicators that you can look at, your rate for sputum conversion, you can look at completion of therapy, but we're also monitoring for sputum, for clinical and radiologic response. So they're on their meds. What are you looking for clinically when you're doing your face-to-face? What would you expect? Patients on treatment? They're feeling better. What symptoms are going away? Cough. What else? What? Fever, gaining weight. And have you had patients who say they didn't even realize how bad they felt till they started their meds, and they're like a whole new person, right? It's like this weight lifted off their shoulders because the medicines are very effective. And then, of course, hopefully we address other health problems. Now, just briefly on co-management, you can either do it all, or you can have the physician, your private doc, do part of it. We have an MOU with our managed care plan that we do all their TB follow-up, but they're supposed to pass. So, it's a fee for service. So you can think about that in terms of resources. Again, we won't treat, offer their orders. Our physician has to see them at least once. No, in California, a resource for us is the Gotch Law, right? Everyone's familiar, requires discharge approval by public health before the patient can be discharged with confirmed or suspect TB. Effective law most of the time, every once in a while, someone discharges without approval. So then here's my role as the controller, is not to say, oh, shame on you, you discharged that patient without my approval. Although sometimes I feel like saying that, but I don't. I go, oh, could you please, I call the IP. My Lincoln Hospitals is an infection preventionist. Very good resources, very important to maintain a good relationship. I'll call up and I'll say, can you tell me what happened? You know, please review, do a quality improvement review, and I request that they do an incident report and they have to give me a corrective action plan. Right? Because it's a law in California. It's not just they didn't want to do it, it's a law that they have to do it. And so one time we had a patient discharged without approval that went to a skilled nursing facility. Was not clear. So when I found out, I called the nursing facility and I said, send them back. They cannot be there. They are not clear. You're putting your patients and your staff at risk. So know your protocols. It's the case manager. You may not be the one responsible for that type of activity, but it would come to your attention that this patient's in the hospital. Make sure that discharge approval is done. Why? One, we want to make sure the patient's on appropriate treatment. Two, we want to make sure they're safe to go to whatever environment that they're going to. And then we need a plan for continuity of care. All of that, very important. Now, when you're co-managing, you still have to sign a case manager. You have to do a risk assessment for non-adherence, doing the DOT if indicated. The standard is, you know, the gold standard is DOT. But interesting, when you read the ATS guidelines, the new one, it actually says, well, there's no true studies, right? Controlled studies to say SAT is better than DOT. I was surprised to read that, because that's been the gold standard forever. But expert opinion and the anecdotal things that people on DOT do better, right? They finish treatment more often, their disease progresses less, they convert sooner, is still the gold standard. So that's what's expected, is that you have them on DOT. You need to maintain surveillance, even though the private doc is following them. Make sure contacts are evaluated. And again, you have to ensure we're carrying out our responsibility to protect the public. In summary, as a case manager, you have a lot expected, or we have a lot expected of us, right? So you want to develop strategies and services to meet the patient's needs. The goal, again, is for the patient to complete an adequate course of treatment. Very important. Remember all the things that go with that. You want to do everything you can to educate, support, incentivize, bribe, provide enablers, everything we can to help that patient. What's our goal? We want them to get treated. We want them to go back to living a productive life in our society. And then you have to elicit the support of the physician, the social worker, outreach staff, mental health or behavioral health specialists, because we cannot do it all by ourselves. It does take the team working together to ensure the best outcome for our patients. Thank you.